All right. Well, I think it's 8 o'clock and we're just about ready to begin. It is a distinct honor today to have a very special speaker, Dr. Douglas White, courtesy of the wonders of WebEx and video conferencing. So Dr. White is professor in the Department of Critical Care Medicine at the University of Pittsburgh. He's spent much of his formative years in medicine at UCSF, where he was a medical student, then internal medicine resident, and a pulmonary fellow. While there, he also obtained his master's in epidemiology and biostatistics, and then, because he wasn't trained enough, added an additional fellowship in clinical ethics. He stayed on faculty at UCSF until 2009, when he was recruited to Pittsburgh to take on the director of their program in ethics and decision making in critical illness. And he has risen to the ranks of professor there, as well as currently vice chair for faculty development. He's gotten many honors and awards over the years, but I will say I think the most striking listed in his honors and his awards was his selection as Expedition Medical Officer for the 98 American Mount Everest expedition. We'll have to have him come back and talk about that at a different Grand Rounds. Um, but and a little more down to earth, but no less impressive, recently elected to the American Society of Clinical Investigation. His research is focused on the ethics in the critical care setting, including decision making in the ICU, the use of surrogates, examination of family centered interventions, and he's had a long-standing interest in ICU rationing and medical futility for almost 20 years and is widely recognized as a leader in this field. And as many of you might have read recently, he and Bernie Lowe, one of his former mentors from UCSF, came out with a really nice framework in JAMA, a framework for rationing ventilators and critical care beds during COVID-19 pandemic. And he really is a wise and sage person, a wonderful speaker, and I am absolutely delighted to have Dr. White talk to us today about fair allocation of scarce ventilators and antiviral medications during the COVID-19 pandemic. And before Doug starts, I just want to call your attention to the text. So please text to the number 37607, and in the body of the text message, please write Douglas 161. That will enable you to participate in the audience interaction polls. And we've got it in the I think it's in the chat box. Yes, it's in the chat box. So please do that. It'll be more fun and more interactive. So with that, Dr. White.
Great. Dr. Schnapp, thanks so much. Thanks for having me. I hope everyone is doing okay in these times. So I am going to be talking today, if I can advance my slides. There we go. About fair allocation of ventilators and COVID-19 medications during the pandemic. I think we have a little bit of a lag in advancing. Okay, perfect. So I'm going to give you guys a few tough ethical decisions throughout the talk, mostly at the beginning, and I'd love to see your responses. I think it will help inform the conversation. So as Dr. Schnapp said, please text to 37607 Douglas White 161, and then as the polls come up, all you need to do is text A, B, C, or D to that same number, 37607. Okay, so the things that I'm going to cover there are three main topics. First, I'll describe the ethical considerations that are relevant when allocating scarce resources during a public health emergency. Second, I'll present an operational way to allocate ventilators and COVID-19 medications that are based on those ethical principles. And third, and I think really importantly, I'd like to spend some time highlighting strategies to mitigate what we are now seeing, which are really disproportionate impacts of the pandemic on disadvantaged communities. Okay, so to really get yourself into the context that we're talking about, for those of you who don't practice inpatient medicine, This is a picture from one of the intensive care units in Lombardy, Italy, in mid-March of 2020. Lombardy is in the northern region near Milan. This is a very wealthy area of Italy, and they were simply overrun by patients with acute respiratory failure. So for just to give context, you know, this is from one ICU that had, one hospital that had about 70 ICU beds in total across the hospital. They were seeing between 50 and 70 new patients a day with acute respiratory failure requiring mechanical ventilation. So you can see that within a day, their resources were overwhelmed. And then the next day, 50 more patients would come in with acute respiratory failure. And the next day, 50 more. So this was not a theoretical exercise in Italy. And they were rationing ventilators at an incredibly high rate. So I think what I'd like to do is sort of get you in that mindset of, if you were the person that were charged with deciding which patient should get a ventilator, as there are far fewer ventilators than patients who need them. Let's start with a poll here. See if I can get there we go. Okay, so I'm going to pull up the poll. It's activated. All right, so the first question, just to get you guys started with the poll, is where are you while participating in this grand rounds? Are you at one of Wisconsin's many fine bars that are open during the pandemic? Are you in bed, of course? Are you peering into the refrigerator? Or are you very hard at work? I promise, Dr. Schnapp. All right, great to see that people are either about to go to work or already hard at work for Dr. Schnapp. So let's go on to the next question. Imagine that you are responsible for making allocation decisions in your hospital. You have one remaining ICU bed and one ventilator. Which of the following two patients would you choose for care? A 45-year-old woman with acute respiratory failure, no severe comorbidities, and a 75% chance of survival to hospital discharge. The key difference is the 75% chance of survival hospital discharge. The second patient, a 45-year-old woman with acute respiratory failure, shock, acute renal failure, DIC, and a 10% chance of survival to hospital discharge. Or would you flip a coin to decide? Okay, so we're seeing the vast majority of people would prioritize the patient who is much more likely to survive. Let's go on to another one. The next, you have one remaining ICU bed and one ventilator. Which of the following two patients would you choose for ICU care? The first is a 45-year-old woman with single organ acute respiratory failure. Again, they all require mechanical ventilation in order to survive. Everyone will die without it. This individual has no severe comorbidities and a 75% chance of survival to hospital discharge. Second, a 45-year-old woman who, rather than having no severe comorbidities, she has advanced lung cancer with less than a year to live, and she has a 75% chance of survival to hospital discharge also. Or C, would you flip a coin to decide? So the key difference here is, does the duration of survival matter? The fact that patient B is expected to live less than a year compared to patient A, who does not have a poor prognosis in the near term. Or C, it doesn't matter, you should just flip a coin between the two. All right, what I'm seeing is a vast majority of respondents think that the person with no severe kind of end-of-life comorbidity should get priority. All right, and then the last one, again, one remaining ICU bed, one ventilator. Which of the following two patients would you choose for ICU care? A 13-year-old girl with acute respiratory failure, no severe comorbidities, and a 75% chance of survival to hospital discharge. Or a 90-year-old woman with acute respiratory failure, no severe comorbidities, and a 75% chance of survival to hospital discharge. Or would you say it's impossible to discern between these two? I'm going to flip a coin. And again, the key distinction between these two, they're identical other than the prognosis, other than the patient's age. All right, so again, a vast majority of people are saying that age does matter to some degree, and I think it's really important to talk through the ethics of each of these, and that's really my goal for the day, is to help unpack what might be lying behind our moral intuitions about these cases. So my work on this began actually in 2008, 2009. Just before the H1N1 pandemic that many of you will remember, which killed hundreds of thousands of people across the globe, and really was the first main pandemic in the 2000s that got the US government's attention in the sense that there was concern that we would not have enough ventilators to go around. And when I looked around as an intensive care physician, part of my work was thinking about, well, what approaches do professional societies or states recommend? And the existing ethical guidance at the time, if you looked up mass casualty or rationing ventilators, was a document published in CHEST by the Task Force for Mass Critical Care, which was a combination of 10 different professional societies. And it was about how to allocate scarce resources in a mass critical care event, such as a pandemic. And the key thing about the way that this group proposed to allocate was, one of the main approaches was to first exclude large groups of patients from any access to ICU care. And this is embodied in the Alabama state guidelines that you may have heard quite a lot about recently, that they were struck down as violating discrimination law. But the kind of things both in the CHEST framework and in the Alabama state guidance that they said, quote, do not offer mechanical ventilator support for patients with any of the following: severe mental retardation, moderate to severe dementia, New York Heart Association class 3 or class 4 heart failure, or COPD requiring HOMO 2. And I would also just point out, I'm sure you can't read this on the slide of the CHEST document, but advanced age was also an exclusion criterion in the CHEST, the original CHEST document. And I think that those criteria for exclusion are ethically problematic, especially because they are diagnosis-based. And there are a few reasons for that. First, I think using diagnosis is the wrong tool for the job, in the sense that most chronic disease states are insufficiently predictive of a poor outcome to use as a hard and fast exclusion criterion. And I think the cleanest example for that, and what really drove it home for me, was the example of a 50-year-old person admitted to the ICU who has class 3 heart failure, which would have gotten them excluded according to the CHEST and Alabama guidelines, but they're admitted with an opioid overdose, not a heart failure exacerbation, such that with 7 or 8 hours of mechanical ventilation and some Narcan, that patient would be walking out the door the next day, which is to say their prognosis to survive the hospitalization and in the near term was actually quite good. And the mere diagnosis of class 3 heart failure was not predictive of a poor outcome. Second, and just simply, these exclusion criteria, as we'll talk about later, violate US anti-discrimination law. Categorically excluding patients based on disabilities violates the Americans with Disabilities Act. Third, and I think relatedly, from an ethical and social standpoint, excluding people in this way, I think essentially sends a message that some lives are just not worth saving at all. And that is a really problematic message in a public health emergency. And then fourth, this approach of categorically excluding individuals violates a fundamental principle of public health ethics, which is to use the least restrictive means possible to accomplish the public health goal. So if you can actually allocate resources without simply excluding large groups of people, you should. And so we set out to develop a framework that would do that would allow allocation to occur without excluding large groups of patients. And I'll present it here. We published this in 2009 in Annals of Internal Medicine. Bernie Lowe, John Luce, and Mitchell Katz were the other co-authors. And I'll just note that Mitchell Katz is now the director of public health in New York and has been deeply involved in New York State's response to this. So the three main recommendations for what not to do that we proposed were: number one, do not categorically exclude patients based on specific diagnoses or perceived quality of life. Number two, don't consider social worth, in large part because there's no accepted metric for this and there's a huge risk of bias. We saw this with the allocation of dialysis machines when they first came out. The committees that allocated these machines preferentially gave them to homeowners family members, and economically active individuals rather than people who might have a different conception of what it means to live a good life. And obviously lots of concerns about bias come up there. And then third, we recommended to not use a first come, first serve strategy because number one, it will lead to quite idiosyncratic results. And number two, it's probably unfair to those with barriers in access to hospitals and care. The disabled who have difficulty, for example, even getting in a car to get to the hospital in particular would be disadvantaged. And we proposed that there are three main criteria and maybe a fourth that should be incorporated. First, achieve medical benefit for communities, and we proposed using priority based on likelihood of survival and priority based on duration of benefit. And I will say here, I want to flag the duration of benefit one. I don't think we got it quite right the first time around, and I'll talk a little bit about how, but I do think duration of benefit is an ethically important criterion. Third, prioritize those who've had the least chance to live through life stages. And then fourth, and I'll unpack this in a later slide, potentially prioritize essential workers, not because they are more socially valuable writ large, but because they are central to the public health response. And so let me just unpack why each of these is important. First, why is likelihood of survival an important allocation criterion? Well, simply put, it's a core principle of triage ethics to use scarce resources in a way that optimizes population outcomes. And giving the scarce resource to people who are more likely to survive than less accomplishes that goal. But I would also say that that's an insufficient criterion in the sense that duration of benefit should be considered to some degree. This is an established ethical principle for scarce resource allocation. If you look at the AMA Code of Ethics under allocating scarce resources, duration of benefit is one of the accepted criteria. I'll also point out that it's already entrenched in how we in the US allocate scarce resources, particularly, or for example, organs for transplantation. The one that I know the best is the score for lung allocation. It's called the lung allocation score, and it strongly considers individuals' likelihood of surviving in the year after hospitalization. And the way that the lung allocation score ends up working, it's not, are you expected to die in a year? And if no, then you have equal priority. It's how likely are you to survive for at least a year? And what you end up seeing is that the average patient who's selected survives for more than 5 years after transplantation. So they're really looking for patients who are likely to survive for more than a year. And then finally, I would just point out that using these criteria comports with many citizens' considered moral judgments. You know, the poll that you just did strongly reflected that at least this group believes that likelihood of survival and duration of benefit, duration of benefit in the near-term prognosis sense does matter. So what about life cycle considerations? This is one that facially I think raises a lot of people's questions about, well, isn't this just discrimination against the elderly? I would say that the ethical justification is not based on social worth or considerations of utility of older or younger people, because, well, for several reasons. First, remember that unlike one's race or ethnicity or gender, we are all going to age. So the sense of age as a criterion is egalitarian in the sense that we all experience it. And when you think through the young versus the old, the young are the worst off in the sense that they have had the least chance to get something that we all think is important, which is the ability to live a full life and through the stages of life, to live through childhood, young adulthood, middle age, and old age. And it's egalitarian in the sense that we want to try to give everyone an equal chance to experience this thing that we all hold as one of, or if not the most important aspect of being alive. And there is very strong support for this, for incorporating some consideration of life cycle in this. And I would point out that the audience also had a very strong view on this in terms of favoring giving it to the 13-year-old girl rather than the 90-year-old. And then finally, what about prioritizing essential workers? This one is controversial too, but I want to make a clarification about what we mean. We don't simply mean healthcare workers, which is a predominantly privileged white group. When I say essential worker, I mean the full range of people who are being called on during the public health emergency to be physically present at work. And this is healthcare workers, people in custodial services at the hospital and elsewhere, agricultural workers, bus drivers, grocery store clerks. All of these individuals should be given, in my view, some heightened priority, not because they're intrinsically more worthy, but because they have an instrumental value in safeguarding the public during the pandemic, not to mention the fact that they are putting themselves at significantly higher risk than those people who have the ability to shelter in place. All right, so I've just laid out a number of ethical considerations that it is great in theory to say, yes, all of these things are important. It's a whole other thing to think about, well, how can we actually operationalize this into an allocation framework? And what we proposed in the Annals paper in 2009 was not, we didn't propose this should be the way. We just said, here's proof of principle that you can put multiple allocations criteria into a single framework. And so what we proposed, we just said, listen, here are 3 criteria that we think are important: save the most lives, save the most life years, and the life cycle principle. And we proposed a point system such that for each of these considerations, points were assigned. So for save the most lives, we put in here the SOFA score. Not that I think the SOFA score is the best one, but just as an example, if your SOFA score is very low, you get 1 point, all the way up to if your SOFA score is very high, which means you have a very high risk of death, you get 4 points. And obviously in this point system, more points means lower priority for access to a ventilator. Similarly, for save the most life years, we proposed, and I think we got it wrong, that if you have no conditions that limit long-term survival, you should get 1 point. If you have severe conditions where death is likely within a year, you should get 4 points. And then these are the ones I think we really got wrong. Somewhere in the middle, if you have minor comorbidities with a small impact on survival, you should get 2 points. That's a mistake in my mind. And I think we were insufficiently attentive or frankly aware of how this would impact disadvantaged communities. And then similarly, the life cycle principle, we incorporated age in these ways such that the young would have relative priority over the very old. And so you end up with a score between 1 and 12 for each patient, and patients with lower scores get higher priority. But everyone is considered, and everyone has a chance to receive care. So that's one example of how to integrate multiple principles into a scoring system. I was really lucky to be able to collaborate thereafter with Lee Daugherty-Biddison and other colleagues at Johns Hopkins who took the 2009 framework and engaged the public in Maryland about it. They engaged a representative sample of more than 300 citizens in day-long deliberative processes where they educated them about the principles. They conducted Q&As with experts, and then they had iterative voting. And what they found was that there was pretty strong agreement for the principles that we articulated in the framework. So 83% of citizens in the deliberative democratic engagement felt that likelihood of surviving the current illness should sometimes, often, or always be considered. 79% felt that likelihood of living longer should be considered. 69% felt that individuals who have lived fewer life stages should be prioritized. And then 79% felt essential workers should receive some priority. What I think is really important is that the vast majority of citizens were against using simple random selection. And then, so that was 2009 through 2014. Fast forward to March 27 of this year, the pandemic was really reaching the United States. We were starting to be quite concerned that we would not have enough ventilators and ICU beds to go around. So Bernie Lowe and I took the work over the last decade and consolidated it. We refined the 2009 Annals framework in ways that really changed how we viewed both life cycle considerations and duration of benefit. And then we proposed a new framework for allocating ventilators that incorporated the public feedback as well. And the key ethical goals of the framework are listed here: to create meaningful access for all patients, which means no categorical exclusion criteria; to ensure that all patients receive individualized assessments, and this is a critical aspect of it for disability rights; to ensure that no one is denied care based on stereotypes or assessments of quality of life, race, gender, or disability. And then finally, we added in a goal to affirmatively diminish the impact of social inequalities on outcomes. Some points of general agreement that we proposed in the framework is that rationing of ICU level care should be the option of last resort, which is to say hospitals have a strong ethical obligation to first increase their surge capacity and cooperate regionally in order to provide ventilators and critical care to as many patients as possible to try to avoid actual denial of treatment. Second, Triage should strive to optimize population outcomes rather than solely individual outcomes. And this is a core principle of public health ethics, that in an emergency, the emphasis should shift somewhat to thinking about populations rather than our normal clinical ethic of doing everything we can for the individual patient in front of us. Third, a triage officer, not bedside clinicians, should make triage decisions. And this is really put in place to minimize bias in the decision making, and also to decrease the conflict of commitment that clinicians at the bedside might have if they were asked to both advocate for their individual patient and for the public health goals. And then finally, we highlighted that triage will not only involve allocation at the front to determine who should get into an ICU, but also should involve withdrawing life support from patients who are getting worse and have a poor prognosis once they have received the treatment, in order to provide the ventilator and ICU beds to other patients. And this is a very hard one to think about, but from a pure public health standpoint, it's critical to optimizing population outcomes, that if patients are if they are proving to have a poor prognosis on a ventilator, after a fair duration of a trial, life support should be withdrawn to provide it to others with a much better prognosis. And so this is the revised allocation framework that we proposed in the JAMA paper. The key differences, you'll see that the two principles are save lives and save life years. We dropped life cycle as a main criterion, in part because of the public engagement that said, yeah, we think age is important in terms of the life cycle considerations, but it's not quite as important as saving lives and assuring some duration of benefit. The second thing that you'll notice is that we really changed how we're conceptualizing the life years criterion. And the way we are now thinking of it is that we should only be looking at a patient's prognosis for near-term survival, which is to say the ability to survive for at least a few years after ICU care, akin to how we allocate and prioritize individuals for organ transplantation. So if patients have death expected within a year, they get 4 points. If they have death expected within 5 years, they get 2 points. And this doesn't mean that they have some risk of dying in the next 5 years. This means that the bedside clinician believes that they have a very high probability of not surviving for 5 years. So if you draw the distribution of deaths that likely come up from that, what you would see is that the vast majority of deaths would be in year 2 or 3. Because as you get closer to year 4 and 5, most reasonable clinicians would probably be struggling to say, yes, I'm absolutely sure, or I have a very high probability that this patient will be dead within 5 years. So we propose, again, that if there are ties, and there are likely to be ties, that tiebreakers could be used. The two tiebreakers that could be used are life cycle considerations and essential worker status. You could also incorporate these two criteria as point deductions, so that say someone had a score of 5, if they were an essential worker, you might subtract 1 point, and if they were very young, you might subtract another point. There are a lot of different ways to incorporate multiple allocation criteria, and as I said, we proposed this as an example, and then in the JAMA paper, this is actually what we operationalized as a model policy for the University of Pittsburgh, and then, as I'll talk about later, this was adopted by the state of Pennsylvania. And so I think, as I just mentioned, the state of Pennsylvania, or the Commonwealth of Pennsylvania, adopted this approach on March 22nd, actually before the JAMA paper came out. And there were criticisms that were lodged by disability rights groups. And the core criticism, several of them were, I think, quite reasonable, and several really raised some concerns. So the things that I think were really reasonable is, we did not sufficiently attend to the question of what to do with a patient who comes in chronically on a ventilator. And we very strongly believe those patients should not have the ventilator taken away when they come to the hospital if they have a poor prognosis. So that was one thing we added in response to the concerns. Another concern they raised is we had listed, for examples, diseases that are associated with a poor 5-year survival, just as a guide for clinicians. But the disability rights group said that's discriminatory, because clinicians will, rather than using those as exemplars, they'll use those as the criteria. So we removed that from a revision to the framework. But the disability rights groups, I think, went in a problematic direction, in that they also argued that probability of hospital survival should not be considered, nor should one's prognosis in the near term. And what I think is really important is that the US Office of Civil Rights evaluated the complaints, and the framework was approved essentially as is, with near-term prognosis, hospital survival being incorporated, as well as age as a tiebreaker. The main changes that we made and were released on April 10th had to do with removing the table that listed particular diagnoses and also clarifying that patients on ventilators should remain on ventilators. And so I think, the experience that we had was both really important in engaging with the disability rights community, and I think provided some really valuable lessons for other states and hospitals who are doing this. So we published just earlier this week a piece in the New England Journal of Medicine in which we articulated 6 different recommendations for how to respect disability rights in crisis standards of care. And I'll just go through them quickly. First, we recommended not using categorical exclusion criteria, especially ones that are based on disability. Second, don't use perceived quality of life as an allocation consideration. Third, use near-term prognosis, but not long-term life expectancy, because long-term life expectancy is most definitely impacted by some disabilities, and we felt it is unfair to penalize individuals for somewhat limited life expectancies based on disability. 4, patients' personal ventilators should not be reallocated to other patients. 5, designate triage officers as the decision makers and train them to respect disability rights. And then 6, and I think this is really important moving forward, and it's a step that we've taken to heart in how we're developing our approach to allocating COVID medications, include disability rights advocates in policy development and dissemination. We have learned quite a lot from our colleagues in the disability rights community, and having them at the table prospectively rather than retrospectively is a much better way to do this for all involved. All right, so in the month or 6 weeks since we published that framework in JAMA, it's now, I think, 7 or 8 states that have adopted it as the model for their state's allocation framework: California, New Jersey, Massachusetts, Pennsylvania, Colorado, Oklahoma, and Montana. I don't know if this is exhaustive or not, but I think this shows that there was a real appetite for something other than the approach that starts with just simply excluding large groups of patients from access to care. Okay, I'd like to switch gears and talk now about a bit about what we have learned in the last month about how the pandemic is disproportionately impacting racial and ethnic minorities as well as other disadvantaged communities. I think one of the core lessons that, and this is, I just want to flag for folks, this is a really nice viewpoint that summarizes these issues, published just a week ago in JAMA by Monica Hooper and colleagues from NIH. What's become obvious is that social distancing is a privilege. Many people, especially low-income workers and those who live in tight quarters, are not able to socially distance. And therefore, they are at much higher risk of contracting COVID based on essentially economic disadvantage. Second, we've seen huge inequities in who is getting access to testing and where testing is popping up in neighborhoods, which is another factor that I think has fueled the disproportionate impact in disadvantaged communities. And third, we now have data, really important data, showing that Latino and African American patients are dying at a much higher rate compared to white patients. And these are the data from New York State as of May 7th, where the death rate in Latino and African American groups is double that of white New Yorkers. So a really clear empirical evidence that there is disproportionate impact in certain communities. And so what should we do about that? The next part of this, I want to focus on fair allocation of scarce COVID-19 medications. And what I'd really like to first do is give a little bit of a backstory about what's been going on with medications. So many of you have probably heard by now that the Gilead CEO has authorized the release of remdesivir based on an emergency use exception. And they have released 1.5 million doses across the world. 600,000 have come to the United States. And it is quite clear that that amount is not sufficient for all the patients who would be candidates. And so I think remdesivir is an example of a potential therapy that will almost certainly be scarce. It is in Pittsburgh, and we have been rationing it, and I'll explain how in a moment. But others that are exemplars are convalescent serum, if it's proven to be effective, and monoclonal antibodies. Both of these approaches to therapy are almost certainly to be in short supply for the foreseeable months until production capacity is increased. And just a quick note about remdesivir, just for those of you who have not seen the data on it. This is the emergency use authorization came from a 1,000 person placebo-controlled trial called the ACT trial in severe disease, and they defined severe COVID as patients who are admitted with infiltrates and less than 94% oxygenation on room air. Patients could be mechanically ventilated or on ECMO as well, but this trial didn't essentially excluded people with mild or moderate disease. And the main results, and we have not seen this published in peer-reviewed literature, but it has been released in several press releases, is that in the intervention arm that received remdesivir, the time to recovery was much shorter among those who received the drug compared to placebo, 15 days versus 11. And there was a question of a mortality benefit, 12% mortality in the control arm versus 8% in the remdesivir arm. And so these were the data that justified, in the FDA's mind, the emergency use authorization and the widespread release of remdesivir. So how to allocate this remdesivir, knowing that each hospital that gets it is not going to get enough for all of their patients? Well, Colette de Jong, Alice Chen, and Bernie Lowe published just a week ago now a really nice framework for how to do this. And they proposed similar goals to what we laid out for rationing ventilators, and they're listed here. Prioritizing saving lives, prioritizing saving those with a good near-term prognosis, and prioritizing essential workers. They also said take active steps to avoid discrimination and to mitigate health disparities. And what I'd like to do is just focus down on what they recommended operationally to achieve the goals of prioritizing saving lives and mitigating health disparities. To save lives with allocation, they recommended that during shortages, restrict the use to patients in populations where the efficacy is proven in the RCT, which is to say, for remdesivir, use it only in severe disease for now. And second, they advocated don't authorize compassionate use for other broad indications that have not yet been proven to be efficacious. And third, I think this is really important, they recommended to not use anecdotal evidence to prioritize within the trial population, which is to say, within severe disease. They recommended not trying to discern between people who just need a little bit of oxygen and those who are, for example, mechanically ventilated. Because we right now have no data about whether it's more or less effective in the severest group. It stands to reason that it could be more effective in those with severe disease, i.e. on a ventilator, or it could also be less effective. And their point, I think, is well taken, is that we shouldn't guess about this until we have actual good subgroup data. Right, so what about how to mitigate disparities? They made two recommendations, both of which I agree with, but I think they're not sufficient. First, they said train triage teams to avoid discrimination, totally reasonable. Second, ensure that ability to pay is not a barrier, also totally reasonable. I think each of these will be helpful in not exacerbating existing disparities, but I don't think either of these steps will actually mitigate the disparities across groups and death rates. There's more that we need to do. It's great to say, okay, once they get to the hospital, we're going to do what we can to not worsen disparities. That's step one. But I think there's an ethical obligation to take steps to actually lessen the disparities. And let me just give a sort of a thought experiment about what I mean by this, because you might think, if you just look at the people who come into your hospital or ICU, let's say, for example, that half of them are white and half of them are Black or Latinx. You say, okay, well, listen, fair is fair. We're going to give equal amounts to each of these groups. We're just going to use random selection, and that's fair. That means that we proportionally treat people with disease. There's no discrimination. There's nothing that worsens disparities. It's absolutely true that it doesn't worsen disparities to use a random lottery. You'll end up with what you see here, which is 50% of deaths in the Black and Latinx group and 50% of deaths in the white. But what this ignores is that the Black and Latinx, the 50% of cases in your hospital from the Black and Latinx community is coming from a much smaller population. Let's say it's 25% of the population is Black and Latinx. they're contributing 50% of the cases. So random lottery would not do anything to mitigate disparities. It would just say, okay, we'll just end up that half of the deaths in our population will be in Black and Latinx communities, which means that the death rate in these communities will be double that as in the white communities. And I think that is a clear problem. So instead of that approach of a random lottery, what we propose as a strategy to begin to mitigate the disproportionate deaths in disadvantaged communities is, rather than a random lottery, use a weighted lottery. And I'll explain that in a minute. But what that would do is yield a slightly less disproportionate rate of death within Black and Latinx communities. It won't fix the entrenched disparities, but it is a step in the right direction. And so this is I'll end with just showing you the University of Pittsburgh model policy to allocate scarce COVID-19 medications. This is now posted online. I'm sorry, I didn't put the link up here. If you just Google CCM, critical care medicine, Pitt, it's the first thing that pops up. What's really important about this is that this was a really diverse group of contributors, both critical care and emergency medicine physicians, as well as pharmacists. We had strong representation from diversity and inclusion experts, as well as ethicists and health law experts. And then I think what was most novel is that this was a real collaboration with some remarkable economists from MIT and Boston College, who have been the individuals who have developed strategies for how to allocate scarce spots in charter schools in New York and Boston and Chicago. And they also developed the approach for how to allocate organs for deceased kidney organs for transplantation. And so what we proposed, and I'll just quickly summarize it, is the eligible patients should only be those who met clinical eligibility criteria for the remdesivir emergency use authorization, so staying within the inclusion criteria. The allocation strategy should be a weighted lottery, and the weighting factors should be the three things listed here: enhancing medical benefit, honoring our reciprocal obligation to essential workers, and taking steps to mitigate disparities during a pandemic. And the way we operationalized each of these is that to enhance medical benefit, we should give somewhat lower priority to those who will die within a year from an end-stage condition. To honor the reciprocal obligation to essential workers, we should give some priority to those on the Pennsylvania state list of essential workers. And that's a published list of individuals and businesses that are required to continue physical operations during the pandemic. And then third, and there's a Wisconsin connection here in intellectual contribution, in the sense that we said we should give priority to those from disadvantaged areas. We decided against doing race-based or ethnicity-based allocation for reasons that I can go into, but largely hinge on legal considerations. We instead said to use the area deprivation index as a marker for disadvantage and give some priority to those from the most disadvantaged neighborhoods. We can talk in the discussion section more about this if you want. But Amy Kind, I think from Wisconsin, is really the intellectual leader of using the ADI for various aspects of health services research. And so this is the reality that we're facing in Pittsburgh today. We have 16 courses of remdesivir. We expect that over the next week, or I think actually 2 weeks, that we'll have 64 patients who would qualify for the trial. So we don't have enough remdesivir for everyone. And we developed a lottery system that gives essentially a 1 in 4 chance to the general population. So that's 16 out of 64. So everyone at baseline has a 1 in 4 chance of receiving it. Those who are essential workers have a slightly increased chance, 31 out of 100 chance. Those from disadvantaged areas also have a slightly increased chance, 31 out of 100. And then finally, those who are expected to die in a year from an end-stage condition have a slightly lower chance, 12.5 out of 100. And essentially what we do, just to sort of make clear how we operationalize this, is that when a new patient comes in who meets criteria to receive remdesivir, we confirm that. We have an allocation team that's doing the work. We confirm with the primary team each of these considerations. Are they an essential worker? Are they from a disadvantaged area? Are they expected to die in a year? That tells us what their probability is. And let's say that the person is a state worker or an essential worker. They're not from a disadvantaged area. They're not expected to die. They would have a 31 out of 100 chance in the lottery. And so what we do is we use a random number generator to generate a number. And if the number that comes up is 31 or less, they are given the drug. If the number is 32 or more, they're not given the drug. And you see that is a way to operationalize a 31% chance of receiving the drug. So in my two last slides, first, what are the advantages of a weighted lottery over other strategies? First, there are some major problems with using, for example, a first come, first serve approach. It will lead to really unpredictable results in how the resource is allocated, because you don't know who's going to get infected earlier or later. Second, it's likely biased against those with poor access to care. And third, it does nothing to overcome disparities, right? It's because it's unpredictable who will receive more or less. It just doesn't reliably address disparities. All right, well, what about problems with a random lottery? First, it will not maximize medical benefit to communities, which is a clear and well-accepted public health goal. You know, the person with advanced cancer who's likely to die within a week would have equal priority in a random lottery to the person who has no severe life-limiting comorbidities. And then also, it will not overcome health disparities. And the thought experiment I just showed you, I think, exemplifies why. What about just saying, well, listen, we're going to restrict to patients with really severe disease, to say you must be on a ventilator? Well, again, just to reiterate, although it's tempting to assume that the drug is more effective in severe disease, we have no data on that point. And so we may, if we guessed wrong about who to give priority to, we might actually worsen population outcomes by making this bad guess. All right, so moving forward, I just want to end with two thoughts to summarize both what I've said and to get you thinking about the health disparities issue a bit more. If we fail to take steps, affirmative steps to mitigate health disparities, our society is going to look different at the end of this pandemic. And the way it's going to look different is that certain groups are going to be missing disproportionately. And that is likely people who are of color and people from socioeconomically disadvantaged areas. And in my view, that raises really profound justice concerns. Second, if we don't take steps to mitigate disparities, I think there's likely to be a very problematic erosion of social trust because of the unfair treatment of certain groups during the pandemic. And I'll just end by saying there are simple steps we can take to lessen the inequities. I think some of the things that we've talked about today are some of those. But access to testing certainly is another one. It's obviously a bit beyond the scope of this talk, but I think at multiple levels, there are simple steps that we can take to lessen the inequities and outcomes. Thank you, and I'll end there.
Great. Thank you, Doug, for a really wonderful and thoughtful presentation. And we are open. So a question from Dr. Ellenbach, who is working with a group in Wisconsin to create state guidelines for allocation. And there's been a strong reluctance on the part of state leadership to help contribute to these guidelines in a politically divided state. Not that it happens anywhere. Can you share your experience in Pennsylvania and give some tips?
Well, yes. So I love Pennsylvania. I'll just describe Pennsylvania as you have Pittsburgh and you have Philadelphia, and Lynn knows this, and everything else in between is Kentucky. So there's Pennsyltucky is the very rural regions of Pennsylvania that have very different views than the city views, for example. Bill, it's a great question. You know, I don't have great tips because I don't really know the inner workings of Wisconsin politics. What I will say, though, is I'm part of the Pennsylvania Advisory Committee for Allocation of Scarce Resources that advises the governor, and they have been incredibly responsive to the concerns that we've raised about equity and the need to truly engage with public health principles in order to maximize population outcomes. It has required advocacy in order to do it. But I do think the steps that we've taken to put out a model policy first have nudged states and given them a view of how you can do things beyond, for example, random allocation.
So one question I have for you, Doug, is you talked about resource allocation being a last resort, and that also implies that there is potentially some sharing of resources within a region to ensure that there's not disproportionate restriction based on, hospital A having an overabundance of ventilators and hospital B potentially in a under-resourced area having much less. So what are your recommendations for kind of regional distribution in that?
Yeah. So, Lynn, let me answer with drugs first. I think that's the most pressing thing right now. Is that okay? Or are you more interested in ventilators?
No, however you would like to address it, it'll be fine.
Okay. So I think the way that it's playing out in Pennsylvania, it may be the same in Wisconsin, is that the state has gotten the allocation of drugs and they have proportionally distributed it to hospitals. That is challenging because there's nothing about a particular hospital that means they should get more or less. In theory, this really should be regionalized. And in my view, there should be 6 or 7 regions in Pennsylvania that each have a supply of drug, and the hospitals in that region should call in and say, we have an eligible patient, here are the criteria, and the lottery should be run centrally. And then that person in the central office who is a public health official should say, okay, here's your person's result of the lottery, and we either are shipping drug to you with a courier or we're not. That's how I think it should go. What that emphasizes is that the walls of a hospital, I think, should not be viewed as ethically relevant. It's more we should be trying to focus on the outcomes of populations that we're serving.
Okay, thank you. And so one comment and question came up is, if you're using the area deprivation index, that may bias resources towards cities, and it may enhance perceptions of the major metropolitan areas getting more resources. What's your thoughts on that?
Well, I mean, I don't know what the demography of Wisconsin is, but if you look at the area deprivation index map for Pennsylvania, you see quite a lot of deprivation in rural communities. It's striking that the red in the map is the very deprived areas, and the bright yellow is the red really deprived areas. And for Pennsylvania, it's actually quite spread out across the state. I would also say that the ADI, at least in Pennsylvania, is tightly correlated with who's getting infected. And so that's an appropriate way to at least even just proportionally allocate resources. So if rural communities are being less impacted, I think less drugs should go to rural communities.
And do you see this allocation model also being used when a vaccine becomes available?
Yes, in broad terms. I think there should be a weighted lottery or some sort of, there's also something called the categorical reserve system that is a sort of a fancier way to do it. I wouldn't yet want to say it should be exactly the same weighting and the same considerations, because I think vaccines do bring up different concerns. I think how we often think about allocating vaccines is that there are certain groups who are at very high risk and who should be given vaccines first, and that may actually end up being people with pretty severe comorbidities. It may be healthcare workers to keep the workforce in place. It may be children in a different pandemic that hit children hard. And so I think really one of the important things is that the epidemiology of the particular pandemic is in part what should drive allocation. And so I'm certainly not proposing that this approach to allocation is meant to be broadly applied to all future pandemics. It's really based on what we are learning about COVID-19.
And then one of the more difficult things is how to operationalize that triage system during the acute event. If you're thinking about ventilator allocation, for example, how do you separate the decision making from the clinician at the bedside with a triage system in real time? And how do you I think there's also issues with tracking whether resources are available in real time. So any thoughts about operationalizing some of these things?
Yeah, so we spent a lot of time operationalizing the triage system for ventilator allocation at UPMC and at each of our hospitals. And basically at each hospital, we had a triage team that was an intensivist or a hospitalist, as well as a nurse and someone to help with data management, literally someone to enter data as we went to know who are all the patients who are eligible. And essentially the triage team every day was told, here are the number of beds that we have, ICU beds that we have open and ventilators. Here are the average number of patients that have been admitted over the last 5 days. And here are patients who have been on the ventilator for 5 days, 6 days, and we're hearing from their clinicians that they're worsening. And so all of that information gave the triage officers the sort of what we call situational awareness to be able to say, here are the resources available in our hospital so that we can make thoughtful decisions about how many patients can get a ventilator. We never had to use the system, but we went through a number of dry runs and found that it was quite feasible to have one team do this for the hospital. They basically spent their time between our 4 ICUs and the emergency room, and it was a feasible approach.
Okay. All right. I think, let me just make sure nobody.
Well, Lynn, I actually have a question for you all, if that's okay. So I know a little bit just from some email exchanges with how things are sort of happening with allocation of ventilators. I think at the Wisconsin hospitals, at the University of Wisconsin hospitals, but I'd love if Bill or Gretchen has updates on how you are thinking about, particularly around, is near-term prognosis relevant, and if not, why? Because I think that's a really important conversation to have.
Yeah, so I think that's a great question. I think the good thing in Wisconsin is we have not been um, forced to have many of those discussions. Our numbers have been relatively low, and we have not been to the point of requiring triage or even start thinking about triage. Uh, and I'm hoping, I know Bill's still on this call of what, if Bill wants to chime in. I'm not sure what our current protocols are right now. I think that is something that we're going to need to rethink, particularly as the state has lifted the stay-at-home orders, and you've probably seen pictures on the media of our bars completely packed without any social distancing. And so there's obvious concern that we're going to see a resurgence in the near future. Um, so, but Bill's chiming in. Thank you, Bill. The University of Wisconsin guidelines are very similar to what you've published, and we had survival of less than 1 year as a criteria.
Got it. Okay. Yeah.
The good news is,
I think it's great. If I could just say, we've thought a lot about what to do with survival. So survival of less than 1 year. If you really look at that, what you're going to get is people whose average survival, if your criterion is death expected within 1 year, to be certain that death is going to happen within a year, you're likely going to get people who are going to die much sooner. And so it does raise this question, what about the patient, for example, with advanced cancer or advanced Alzheimer, who you can't say, listen, they're almost certain to die within a year. And instead, maybe, if they have a FAST score of more than 7 for Alzheimer's, which is associated with about a median survival of 1.5 years, should that person have equal access to someone who is 18 and is similarly ill in terms of prognosis for hospital survival? I think many people's considered moral judgments would be no. The person who's expected to live for many years should be given some priority over the person who's expected to die within a few. And I would just raise that the less than 1 year criterion leaves the situation that I think is somewhat problematic, that those two people that I just explained would have equal priority.
Yeah. I think that's a great point. And one last question. So One of the things you talked about is that the allocation of resources should be addressed continuously, so not just upfront, but need to readdress. One of the tricky questions in COVID, particularly, is when is somebody not responding to treatment, and the duration of ventilation that we're seeing in these patients. So your thoughts on that?
Yeah, so it is, we have learned a ton about the disease. And, I think what's amazing is that if you look at the existing guidelines from 2008 and then 2014 about how long these trials of intensive care should be, it was usually something like 24 and 96 hours. And that is far too short for COVID. These patients stay on ventilators. I guess the better way to say it is survivors stay on ventilators for a very long time before they come off. And so what we operationalized was that as long as the patient is the same or getting better, they should retain the ventilator indefinitely. So as long as they are not really worsening, they should retain the ventilator. It's only people who, for example, are developing severe multi-organ failure and moving toward death from multi-organ failure rather than single organ respiratory failure. It's that former group that should be considered for ventilator withdrawal.
Great. Well, I think we're out of time. There's still a number of questions that I'm sure Doug would love an email, and happy to discuss any of those questions further. So thank you for a wonderful Grand Rounds, really thoughtful and provocative Grand Rounds. Just to give you some updates for everybody. So next week we are taking a Memorial Day break from Grand Rounds. So no Grand Rounds next Friday, but we'll resume the Friday after. We've got Jeff Drazen coming up to give us Grand Rounds, who's the former editor of New England Journal of Medicine, who is a fantastic speaker as well. And Dee Ford will be talking about telemedicine in the future. And Betsy Trowbridge is on the coming up at that as well. So we've got a great lineup for June. I want to thank Doug again. I told him I owed him a visit and a dinner in Wisconsin at some point in the future. Great. So thank you all for tuning in, and we'll see you soon. Bye-bye.